today's class will be on the CKD. So the definition of the CKD, two things you should see that whether there is a abnormality in the kidney structure or an abnormality in the kidney function presents for more than the 3 months. That is the definition of your CKD. Okay. So what are the markers of the kidney damage? So these are the markers like albuminuria. Okay. Albumin creatinine ratio more than 30 milligrams per gram. Urine sediment abnormalities. Electrolyte and other abnormalities due to tubular disorders. Abnormalities detected by the histology, so renal biopsy. Structural abnormalities detected by your imaging. History of any kidney transplantation, past history of the kidney transplantation. So these are all the markers of the kidney damage. Whereas the marker of the kidney function is your reduced GFR. So decreased GFR less than the 60 ml per minute per 1.73 square meters is your parameter to say the person is having a CKD. So early detection and management are crucial to prevent the complications and improve the patient outcomes. So CKD is a very, very big disease in India. So because of the very common etiological factors to cause CKD, like your diabetes or hypertension, obesity, glomerulonephritis, analgesic nephropathy, septicemia. So these are all the reasons to cause the CKD in our individuals. So the early detection of the CKD is very, very important. Again, unfortunately, most of the CKDs, by the time they are the symptomatic, the GFR is already less than the 30. So even at the 15, what you consider as a end-stage renal disease, even with end-stage renal disease, very few people will have a symptoms. So not your regular uremic symptoms may not see even at the GFR of 15 also. So as a physician, you should recognize the CKD at an early stage, maybe the stage 2 or the stage 3, so that you can avoid the precipitating factors which cause the CKD, and then we can give good quality of the life. The same thing here. Okay. Albuminuria here, albumin creatinine ratio more than 30 milligrams per gram is considered, gram is considered as a marker of the kidney damage. This is your heat map. You all know that. On one hand, you have the GFR. On the other hand, you will have the albumin creatinine ratios. So accordingly, you can say whether the person is at low risk or the mild risk or the moderate risk or at high risk or very, very high risk. See, if you see here on the GFR side, so more than 90, we consider as the normal. But if the albuminuria is more than the 300, so definitely it is of very high risk individual. So if you don't consider albumin creatinine ratio in a fellow whose GFR is more than the 90, you may think that this individual is at very low risk or the no risk of getting the CKD. But if you add the albuminuria, so you can if you add the albuminuria, see here in the C side, that is the yellow, so that shows already moderately increased risk of getting the CKD individuals. In the same way, if the albuminuria even at a lower level, when the GFR is more, so definitely the person is at a very high risk or very, very high risk. So to consider a person who is at a risk, high risk or the higher risk, you have to see the both the GFR as well as the albumin creatinine ratio in all the individuals. So this is the GFR categories. You all know that more than 90 is the normal, 60 to 89 or 60 to 90 is the category 2, that is a mildly decreased, usually asymptomatic. When the GFR is between 30 and 60, again we will divide into the two groups, 3A and the 3B. A is 45 to 59, mild to moderately decreased. Most of the people are asymptomatic here. 3B, the GFR is between 30 to 44, moderately to severely decrease of your GFR or your kidney function, but still most of the individuals are asymptomatic even at this juncture also. When the fourth category, you have the GFR between 15 to 29, that is 15 to 30, the severely decreased, some people may have a symptoms here. When the GFR is less than the 14, so there is a true kidney failure, these people may have uremic symptoms. Okay, so these are the clinical presentations when compared to your GFRs. See the markers of the kidney damage, like your nephrotic syndrome, nephritic syndrome, tubular syndromes, UTIs, asymptomatic urine analysis abnormalities, asymptomatic radiological abnormalities, hypertension due to the kidney disease. So these are all seen when the GFR is between. You have to see these things to rule out any renal pathology in those individuals. Between the 15 to 60, so mild to the severe complications like anemia is a very commonly associated here. Mineral and bone disorder, that is the elevated parathyroid hormone. Cardiovascular diseases are very, very common in this juncture. Hypertension, lipid abnormalities, not only these two, coronary artery disease or ischemic heart disease is also very common when the GFR is between 15 to 60. And of course, low serum albuminuria, then the people will have the pedal edema, etc. Most of these people CKD, they may not reach the stage of end stage renal disease or a stage of the kidney failure when the GFR is less than the 15. Mostly these people, they die prematurely because of your cardiac complications. So very few people will reach the end stage renal disease. And this, at the stage of the end stage renal disease, only two options are there. That is the renal replacement therapy, either in the form of the dialysis or in the form of the transplantation. So again, the dialysis of two types, the peritoneal dialysis and the hemodialysis. So this is albuminuria categories in the CKD. A1, here it is less than the 30, they are the normal individuals. When the albumin creatinine ratio is between 30 to 300, that is a moderately increased, or you consider it as the microalbuminuria. And the more than 300 is the macroalbuminuria, that is a severely increased. So albumin categories are very, very important, because a spot urine test is always important along with your creatinine levels to assess a proper renal function in that particular individual. So you all know that microalbuminuria is a risk factor for the renal disease. It is a risk factor for your nephropathy. But nowadays, microalbuminuria is also an independent CV risk factor. See, if you see here that the microalbuminuria, the inflammation and increased CV risk and the vascular dysfunction. When it is the macroalbuminuria, that means the albumin excretion is more than the 500. We consider as 300 to 500, we consider as the macroalbuminuria, or more than the 500 is the proteinuria. That is a higher CV risk and presence of the CKD and also the vascular dysfunction. So the CV events have been found to increase by 19 to 40% as the glomerular filtration rate declines from 90 to 45. See, half of the patients with the type 2 diabetes and CKD had elevated urinary albumin creatinine ratio without the decreased GFR. See, the GFR, if you calculate the GFR means your creatinine levels, your creatinine clearance. So the creatinine levels appears to be 1.1 or 1.2. But if you don't record the albuminuria, so definitely you are missing some of the CKD individuals here. See, this independent predictor of the CKD, CVD, and also the mortality. See the etiology here, the diabetes, hypertension, glomerulonephritis, polycystic kidney disease, and others like obstruction, especially the obstructive uropathy, maybe because of the prostatic hypertrophy or maybe because of the carcinoma cervix, etc. And also the infections like a chronic urinary tract infections or pyelonephritis, etc. See here the diabetes of 28%, but that is the old study. But now the present study in the diabetes is the most common cause of the end stage renal disease, up to the 50%. Okay, 25% is the hypertension and 13% is the glomerulonephritis. So that is the reason if you treat the diabetes and hypertension very effectively, and definitely we can have a less morbidity and mortality from the renal point of view and also from the cardiac point of view. Yes, screening for the CKD. So this is the very, very important to early detection of the disease, as most patients with the CKD are the asymptomatic. So the screening is very, very important for the early detection. The CKD should be detected by performing a kidney health check every 1 to 2 years on individuals who have the risk factors for the CKD. You know what are all the risk factors for the CKD. So all diabetics are at high risk, hypertension is at high risk, glomerulonephritis is at high risk, steroid usage is high risk, obesity is high risk, smoking is high risk, NSAID therapy is in high risk, or any pyelonephritis or chronic urinary tract infections, or BP, benign prostatic hypertrophy, or carcinoma cervix, or post radiotherapy. So these are all the risk factors to cause the CKD. So at least once in a year, so you should check the urea creatinine electrolytes and also the urinary albumin creatinine ratio. Screening should also be considered in those with the clinical risk factors, including the autoimmune disease, mostly rheumatoid arthritis, lupus, etc. These people, when we discussed the LSD, SLE, systemic sclerosis, etc., we discussed about the renal complications of those diseases. So those diseases are also very high risk of getting the acute kidney injury or chronic kidney injury, etc., or tubular disorders. And then the kidney stones, obesity, recurrent urinary tract infections, reduced kidney mass, exposure to certain medications, especially the NSAIDs, or the lithium, or the native medications, or the prior episode of the acute kidney injury, and among the others. So the blood test, the GFR calculated from the serum creatinine. So you need serum creatinine. Urine test, yes, albumin creatinine ratio, and the BP, blood sugar, lipids, thyroid. So these are the common routine investigations one need to rule out the CKD in that particular individuals. But three are very, very important. Your creatinine, albumin creatinine ratio, urine albumin creatinine ratio, and then the BP checking. So what defines your CKD diagnosis? Your persistent urinary ACR more than the 30 milligrams per gram, and persistent GFR less than 60 ml, and other evidence of the kidney damage as evidenced by your other parameters like ultrasound, abdomen, etc. So what to do with the positive result? Repeat and the confirm, and then initiate the evidence-based treatments. So who and when to screen in type 1 diabetes? So type 1 diabetes, you don't get the nephropathy immediately. You can wait up to the 5 years. So 5 to 10 years after getting the type 1 diabetes, one may get this macro or macrovascular complications. But in the type 2 diabetes, even at the time of the diagnosis itself, you should screen to see whether this individual is having a diabetic nephropathy or not. Whom to screen? See, the patients with the hypertension, we screened with the GFR and the urinary albumin. So that is American College of Cardiology and American Heart Association guidelines. All the hypertensives, they should be screened for the GFR and urinary albumin to rule out the CKD. And KDIGO guidelines, universal screening for persons with the hypertension, diabetes, or cardiovascular disease. So these three are very prone to get CKD individuals. An individualized approach to screening was recommended for persons with other clinical, environmental, or genetic risk factors for the CKD. CKD screening must include the assessments of both GFR and albumin. So these are all the etiopathogenesis. Already we discussed the diabetic kidney disease. So you have to take the history of the diabetes, the duration of the diabetes, the level of the control of the hyperglycemia, and about the proteinuria, and most important is the retinopathy, because retinopathy and nephropathy are very, very closely interrelated. So all the retinopathy people should be screened for the nephropathy, and the same vice versa. Hypertension, so elevated blood pressure, urine analysis, any family history of the hypertension with CKD. So these will help you a lot. Among the hypertension, again, a primary hypertension or the secondary hypertension. So secondary hypertension, the most common cause is renal artery stenosis or renal parenchymal diseases like glomerulonephritis or pyelonephritis, polycystic kidney diseases, or renal tubular acidosis, analgesic nephropathy. So these are very, very important renal causes to cause CKD. Non-diabetic glomerular disease, nephritic or nephrotic presentations, cystic kidney disease, urinary tract symptoms, abnormal urinary sediment, radiological imaging abnormalities like polycystic kidney disease is very common in some individuals. Tubulointerstitial disease, history of the urinary tract infections and the reflux Chronic medications, especially your antibiotics or NSAIDs or steroids, etc. Drug exposure, abnormalities in the urinary tract imaging, tubular syndromes, including the urine concentrating defect, abnormal urine analysis. What is the pathology and pathogenesis? A chronic versus the acute renal failure pathogenesis. In acute, there will be the tubular cell death and the regeneration. It is a reversible one, acute. In chronic, it is a irreversible nephron loss. That is the reason we have to give the renal replacement therapy. So what are all the nephrons are there, they are not functioning properly. Whereas in acute, it is a reversible loss. Definitely, if you involve at a right time, so if you remove that exposure, so definitely most of the people will have a normal renal function afterwards. What about the glomerular hyperfiltration? See here the compensatory mechanism with increase in nephron, GFR, predisposition to the glomerular sclerosis, azotemia at 30 to 50, 35% of the GFR, uremia, so less than 20% of the normal excretory capacity. So when the GFR is very, very low, say 15, 20, or we use the word uremia. Uremia means almost stage 4 or the stage 5 of your CKD. Whereas azotemia means a mild to moderate failure. Here the pathogenesis of the uremia, retention of the nitrogenous waste. So these people will have the nausea, vomiting, loss of appetite, etc., sleeplessness, insomnia, etc. Increased intracellular sodium in the water. So there will be the fluid overload, more prone for the congestive heart failure. Decreased intracellular potassium, okay, hypokalemia. Increased levels of the bioactive substances normally cleared renally. Decreased levels of the hormones and other mediators produced by the kidney, and decreased basal body temperature. So the most important is the retention of the nitrogenous waste and increased sodium in the water, hyperkalemia, etc. So this is the creatinine clearance. We use this Cockcroft-Gault equation here. Here the creatinine clearance is equal to 140 minus AS multiplied with the body weight divided by 72 into your creatinine levels. So multiply by 0.05 for the woman. So this is for the male, 140 minus AS into body weight divided by 72 into creatinine levels. So multiply by 0.85, you will have the value for the woman. So this already I told you, according to the GFR, the stages, the kidney damage, the normal, increased GFR, decreased GFR, moderately, severely, etc. Here the point here is, in the stage 1, there may be the normal GFR or maybe the increased GFR also. But when the GFR is coming down from the 60, so definitely you will have a reduced GFR. See, there are the clinical manifestations, water retention, sodium retention, hyperkalemia, metabolic acidosis. So the lungs looks like so normal, but the person is tachypneic, small respiration. So these are the very, very common here. A mineral and bone metabolism, so hyperparathyroidism, so osteodystrophy, osteomalacia, osteoporosis. So these are all very common in CKD individuals. That is the reason we give the calcium in the CKD population. Cardiovascular pulmonary disorders. So these are very common because they are living with very low anemia and loss of appetite. All these things, they are more prone for the infections, CKD individuals, especially pulmonary tuberculosis or fungal infections, pneumonias. So these are very common, these pulmonary disorders. Cardiovascular, so pericarditis, that is uremic pericarditis is a very common. Pericardial effusion is common here. So these people are more prone for the ischemic heart disease. So myocarditis or myocardial infarctions. So these are the very cardiovascular disorders, very common. Hematological abnormalities, anemia, sometimes pancytopenia, maybe because of the bone marrow depression. Neuromuscular abnormalities. So these people will have myasthenia like pictures. Gastrointestinal abnormalities, so GERD, endocrine abnormalities, dermatological abnormalities. So we'll go through all these things. So this is the sodium and water balance. So sodium and water retention will lead to the congestive heart failure. So obviously it increases the blood pressures. So hypertension, ascites and edema. So what drug you prescribe here for the sodium and water retention? The CKD. So diuretics. Okay. Which diuretics you use? You have the chlorothiazide diuretics, chlorothalidone you have the spironolactone, you have the loop diuretics like furosemide or the torsemide. So in CKD, what is your favorite diuretic? So it depends on your GFR. So once the GFR is up to the 40 or 45, so you can use the hydrochlorothiazide. Up to 30, you can use the chlorothalidone. And less than the 30, so you have to stop using the hydrochlorothiazide or chlorothalidone. You have to go for loop diuretics. So like furosemide and the torsemide. So most of the times the CKD, by the time you diagnose, by the time the people are symptomatic, the GFR will be less than 30. So in established CKD, your diuretic of choice must be a loop diuretic, either furosemide or the torsemide. Enhance its sensitivity to the extrarenal sodium and the water loss. So the people will have the vomitings, diarrhea, fever, and hypersweating. The symptoms: dry mouth, dizziness, and tachycardia. Avoid the excess salt and the water intake. So that's very, very important in all the CKD population. We ask the people not to take much salt. So even the water also according to the urine output. So you have to respect the urine output, and according to the urine output only you have to advise the water intake. Diuretics are the dialysis, so depending on the fluid overload. So when the fluid overload is very, very high, so definitely we have to subject them for the dialysis also. Otherwise, these people will end up with pulmonary edema. So the potassium balance is very important here. The hyperkalemia. So GFR more than the 5 ml per minute, compensatory aldosterone mediated potassium transport in the DCT. Potassium sparing diuretics are contraindicated here. ACE inhibitors, ARBs, beta blockers. So they impair the aldosterone mediated actions. Exacerbation of the hyperkalemia, exogenous factors like potassium rich diets. So what are the diets which are rich with potassium? All the fruits. So most of the fruits. Okay. So advise not to take the fruits, and also the coconut water. So that also rich with potassium. So endogenous factors like infections in the trauma. Metabolic acidosis, the decreased acid excretion and ability to maintain the physiological buffering capacity. GFR more than the 20 ml per minute, a transient moderate acidosis. Treat with the oral sodium bicarbonate. So we use with nodosis, maybe 500 milligrams. Okay, mostly we use the BD or the TAD. So here to avoid or to prevent the onset of metabolic acidosis. So oral sodium bicarbonate, we use it and then increase susceptibility to the acidosis. Mineral and bone. So this is very, very important. Bone disease from decreased calcium absorption from the gut. So in the CKD individuals, the calcium absorption from the gut is decreased, so leads to the hypocalcemia. Overproduction of the parathyroid hormone, altered vitamin D metabolism. Most of the people is vitamin D is at less than the 30. So normal is more than the 30, maybe less than the 10 also. Deficient or insufficient. A chronic metabolic acidosis. So these are the bone diseases. So bone diseases because of the decreased absorption from the gut, or overproduction of the parathyroid hormone, or altered vitamin D metabolism. So you need to give the calcium here, you need to give the vitamin D3 also, depending on your vitamin D3 levels. See them decreased renal function. So there will be the hyperphosphatemia and decreased 125 dihydroxycholecalciferol and A1-3 intoxication, accumulation of the beta-2 microglobulin. So these are all will lead to the metabolic acidosis. See osteitis fibrosa cystica, high turnover bone disease, osteomalacia, adynamic bone disease, or dialysis related amyloidosis. So these all will lead to the metabolic acidosis also. Cardiovascular and pulmonary abnormalities, because of the volume and the salt overload, so there will be the congestive heart failure and pulmonary edema. So this is very, very important. So unless you recognize the congestive heart failure and pulmonary edema, so these people will be having more and more mortality. Hypertension in CKD is a very, very important. Hypertension could be a cause of the CKD or a result of the CKD or a complication of the CKD. So cause and effect. So when the hypertension, the history of the hypertension of 10 years or 15 years, now the creatinine level is going up. So this is because of the hypertension causing CKD. On the other hand, the no history of the hypertension, now the creatinine levels are going up. Now the BP is also going up. So that shows CKD causing the hypertension. So hypertension can be a cause or a complication of the CKD. Hyperedeemia, you will have the hypertension. And pericarditis. So you have a pericardial rub, uremic toxin accumulation in the pericardium, accelerated atherosclerosis, linked to the factors above and the metabolic abnormalities like calcium alterations, hyperlipidemia, hypoalbuminemia, some platelet abnormalities. So these all will lead to the atherosclerosis, endothelial dysfunction. These are the hematological abnormalities. Anemia, lack of erythropoietin production. So that is the reason anemia and the CKD we treat with the erythropoietin injections. So they are available in the 2000 international units, 4000, 6000, 8000, etc. Maybe once in a week or twice in a week. So we have to give the erythropoietin because erythropoietin deficiency will be there in the CKD. So unless you give the erythropoietin, the correction of the anemia is also very is not possible. So you have to give the erythropoietin like that. Earlier it was very costly, now it is available at a price of maybe 500 or 400 or 300. Okay. Bone marrow suppression, the uremic poisons, the leukocyte suppression, so infection, bone marrow fibrosis, elevated parathyroid hormone, and aluminum toxicity from the dialysis, increased bruising, blood loss, and the hemorrhage, lab abnormalities, prolonged bleeding time, abnormal platelet aggregation. So these are all the hematological abnormalities. So mostly the people will have an anemia of the normocytic normochromic anemia, and some people may have the microcytic hypochromic anemia. Here the anemia is because of the erythropoietin deficiency, so you have to correct the erythropoietin here. Some people may have the bone marrow suppression, where you can have not only the RBC reduction, you may have the WBC reduction and also the platelets also at a lower level. So that shows a bone marrow suppression. What about the neuromuscular abnormalities? The CNS abnormalities, mild to moderate, the sleep disorders are very, very common in the CKD population, and impaired concentration, memory, and some people are irritable because of the CKD. So these are very common in our population, the sleep disorders, impaired concentration and the memory, and irritability. In the severe, these people will have hysterexis, myoclonus, stupors, seizures, and also the coma. So metabolic encephalopathy. Here the reason for this metabolic encephalopathy is your uremia. So in encephalopathy, these people will present with stupors condition, seizures, coma, etc. And peripheral neuropathy is also very common in the CKD. Sometimes restless leg syndromes, maybe magnesium deficiency, maybe the calcium deficiency. Okay, so this is the restless legs syndrome. Hemodialysis related neuropathies. So these people also presents with other neuropathies also. So these are the very, very important neuromuscular abnormalities in a CKD individuals. What about the gastrointestinal abnormalities? So the peptic ulcer disease, secondary to the hyperparathyroidism, uremic gastroenteritis, mucosal alterations, uremic feta, bad breath, ammonia breath, non-specific abnormalities like anorexia, nausea, vomiting, diverticulosis, hiccups. These are common in CKD individuals. So all the systems will be involved in the CKD, not only your nephrological abnormalities, but also a cardiovascular, a pulmonary, gastrointestinal, neurological, muscle. So they are also involved here. Now the endocrine abnormalities. Insulin, prolonged the half-life due to the reduced clearance. So that is the reason these people will have hypoglycemia. And if they get the hypoglycemia, this hypoglycemia is a prolonged hypoglycemia. Okay. So this is insulin because of the prolonged half-life due to the reduced clearance from the kidneys. So you people will have a prolonged hypoglycemia. Amenorrhea and the pregnancy failure, low estrogen levels. Impotence, algospermia, and the geminal cell dysplasia, low testosterone levels. So these are all endocrine abnormalities. Dermatological abnormalities. This is also very common in the CKD individuals, especially pallor because of the gross anemia, skin color changes, accumulation of the pigments. Ecchymosis and the hematomas, the clotting disorders, clotting abnormalities. Pruritus is so common in the CKD individuals. When the creatinine level is going up, most of the people they complaining of the pruritus. This is because of the calcium deposits from the secondary hyperparathyroidism. So this is the dermatological manifestations. The pallor, skin color changes due to the pigmentation, ecchymosis and the hematomas, and most important is the pruritus and excoriations because of the calcium deposits from the secondary hyperparathyroidism. So these are the fluid and electrolyte disturbances, a volume expansion, hypernatremia, hyponatremia, hyperkalemia, hypokalemia, metabolic acidosis, hyperphosphatemia, and hypocalcemia. Endocrine, secondary hyperparathyroidism, adynamic osteomalacia, vitamin D deficient osteomalacia, carbohydrate intolerance, hyperuricemia, hypertriglyceridemia, increased lipoprotein A levels, decreased high density lipoprotein levels, protein energy malnutrition, impaired growth and the development, infertility and sexual dysfunction, amenorrhea, hypothermia, beta-2 microglobulin deposition, and amyloidosis. So these are all the different abnormalities one can see in a uncontrolled CKD individuals. The neuromuscular disturbances like easy fatigability, sleep disorders, headache, impaired mentation, lethargy, hysterexis, muscular irritability, peripheral neuropathy, restless leg syndrome, paralysis, myoclonus, seizures, coma, muscle cramps, dysequilibrium syndrome due to the dialysis, and myopathies. Arterial hypertension, heart failure, pulmonary edema, pericarditis, cardiomyopathies, that is your myocardial involvement, uremic lung, accelerated atherosclerosis, arrhythmias, hypotension, and vascular calcifications. If you see the CT score of the calcium in the vessels, it will be more than 400, 500, 2000. So this is because of the vascular calcification due to the CKD. So gastrointestinal anorexia, nausea, vomiting, uremic fever, gastroenteritis, peptic ulcers, bleed, hepatitis, idiopathic ascites, peritonitis. So the kidney and the liver, and kidney and the heart. So hepatorenal syndrome and also cardiorenal syndrome. Okay. So cardiorenal syndrome and hepatorenal syndromes, these are very, very common, interlinked. Hematological and immunological disturbances like anemia, lymphocytopenia, bleeding diathesis, increased susceptibility to the infections, splenomegaly and hypersplenism, leukopenia, and hypocomplementemia. So managing CKD in conjunction with other chronic conditions. See, most of the CKD individuals, they will have an associated cardiovascular diseases, diabetes, and other comorbidities. So CKD shares many treatment goals and management strategies with other common chronic conditions such as diabetes and cardiovascular diseases. And taking a whole of a person, a 360 degrees approach should be there, and managing the chronic conditions in conjunction with one another will lead to the improved patient outcomes. So we have to treat diabetes plus CKD, or diabetes, hypertension, CKD, or diabetes, hypertension, CKD, IHD, etc. Then anemia or bony health, etc. So whole of a person approach is very much needed in these individuals. That is the reason. So CKD is absolutely a physician's disease. What are the medications considerations in the CKD and the hypertension? ACE inhibitors and ARBs in the CKD care. Integral for the optimal care in all the CKD stages. They are the very, very important drugs. You know how the ACE inhibitors or ARBs will work. So they reduce the intraglomerular hypertension. So they reduces the intraglomerular filtrations. So they help the kidneys in a big way in most of the individuals. Initial use may reduce the glomerular blood flow with a potential GFR decline, that is for the short period only, and continue if the GFR reduction is less than the 25 in the first 2 months. Cease if more than 25% and consider the nephrologist referral. So that is common. Whenever you use the ACE inhibitors or ARBs initially, there will be a little rise in your creatinine levels, or a little rise, a little drop in your renal function. But keep on continuing the drugs, definitely you can have a more and more benefits. But the continuous drop in the renal function in spite of the usage of these ACE and ARBs, and definitely one should stop the using of these drugs. Then you can have an alternative drugs like calcium channel blockers, or the beta blockers, or central acting drugs like artemisinin, etc., or alpha blockers like prazosin, etc. Avoid the combined ACE inhibitors and ARBs. Usually you don't combine the ACE and ARBs, but some nephrologists they may combine the ACE and ARBs, only very few people. So in general, for a physician point of view, better not to use combination of the ACE inhibitors and ARBs. Use with caution if the baseline potassium is more than 5.5. Whenever you use the ACE inhibitors or ARBs as a nephroprotective drugs, please respect the potassium levels. Once the potassium is more than the 5.5, so definitely you have to reduce the dosage of ACE or ARBs, or you have to stop it, because for the fear of the hyperkalemia, this hyperkalemia will potentiate the cardiac arrhythmias, and the person may die because of the hyperkalemia. Here the non-loop and the loop diuretics. Already I told you, non-loop means your hydrochlorothiazide and chlorothalidone, etc. Effective adjuncts in all the CKD stages, especially for the fluid overload. So when the fellows is the fluid overload, when the GIP is elevated, when there is the pedal edema, when the patient is having the rails over the bases, and there is a dyspnea. So definitely these are all the features of the fluid overload. Consider non-loop diuretics if the GFR is more than the 45, and loop diuretics if it is less than the 45. I think loop diuretics less than the 30 is the right answer. Okay. Furosemide is a safe even with a severe GFR function reduction with the dosing considerations. See the furosemide, that is your Lasix, it can be used till the 400 milligrams also. So our tablet of the Lasix contains 40 milligrams. In some countries, no, the Lasix is available in the strength of 400 milligrams also. So one tablet, that means 10 tablets of our 40 milligrams. Hypertension acts both as a cause and a complication that I told you, that presenting the challenges in control. Uncontrolled hypertension escalates the risk, including the progression of the kidney disease, and heighten the vulnerability to the coronary heart disease and the stroke. So the more and more the blood pressure in the CKD is very common. It is very difficult to control the single drug in a hypertension caused by the CKD. You need 4 or the 5 or more than the 5 drugs also to control the blood pressure. So usually we use the ACE or ARBs, we add the calcium channel blockers, and we add the beta blockers, we add the calcium alpha and beta blockers, etc. And then also we add the central acting drug like artemisinin, but still the blood pressure is not under control, or if your goal of 120/80 or less than 130/80. It is very, very difficult to keep the blood pressure at your target in a CKD individuals. Okay, so here we use the high doses of the diuretics also as an antihypertensive medications. So along with these your antihypertensive medications like ABCD, we also add high doses of the diuretic also in the CKD individuals. Why should you treat the hypertension in the CKD? Because CKD, if you don't control the blood pressure in the CKD individuals, these people are at high risk of getting the myocardial infarction, high risk of getting the CVA, high risk of getting the arrhythmias, etc. So definitely more and more mortality will be seen in uncontrolled hypertension in the CKD individuals. It should be integral to assessing the absolute cardiovascular risk. Treatment targets for the hypertension in all the CKD patients aim to maintain the blood pressure consistently below 130/80. It is very easy to say your target of 130/80, but practically it is very, very difficult to reach 130/80 with your usual dosage of these drugs. So you have to use the maximum dosages. For example, your telmisartan, we use up to the 80 milligrams TID also. Okay. In the amlodipine, we use 20 milligrams of the amlodipine in the CKD. If you are a nifedipine, retard combinations are a nifedipine 20 milligrams, we use 60 milligrams nifedipine. In the same way, if you use the prazosin, we use about 10 milligrams TID. Your minocycline, Minipres XL, 5 milligrams, 2.5 milligrams, we use 10 milligrams TID. And the arcomin, again we have to add the arcomin also in uncontrolled hypertension in the CKD individuals. See the doses of these drugs. So respect your pulse rate whenever you are using the beta blockers in the CKD individuals. When the pulse rate is less than the 50, so definitely you have to reduce the doses of the beta blockers. Up to the 50, no problem. So in the CKD is not the bradycardia means not 60. Maybe you can wait up to the 50. So the various guidelines offer the algorithms specifying the suitable agents for the hypertensive CKD treatment, emphasizing the evaluation of albuminuria presence and the severity. Lowering the blood pressure below the target levels is crucial. Prioritize lifestyle changes for the overall improvement. That lifestyle change is also very important. Salt restriction. Okay, it's very, very important to reduce the blood pressure in the CKD individuals. Medication approach for the CKD. Initiate the treatment with ACE inhibitor or ARB for the CKD patients, but to use the ACE or ARB, still the creatinine level is up to 3 or 3.5. So beyond that, better not to use the ACE or ARBs for the fear of hyperkalemia, because CKD itself will cause hyperkalemia, and the drug of your ACE or ARBs also will cause hyperkalemia. Okay. Avoid the combined therapy of ACE inhibitor and ARB. Use maximal tolerated dose of ACE inhibitors or ARB. Not the 50% dose of ARBs, maximum dose. So if you want to use that ramipril, you can go up to the 20 milligrams of the ramipril. In the same way, the telmisartan maybe 160 milligrams or maybe 320 milligrams. That is a maximum dose, maximum tolerated dosages. Monitoring and adjustments. Be vigilant. GFR may decrease and the potassium levels may rise initially. Be careful that if serum potassium is more than the 6, despite the adjustments, consider stopping ACE inhibitors or ARB or spinal. That is very, very important. So multifaceted approach for the hypertension. Multiple medications, often 3 or more, often 4 or more, often 5 or more. So it's very, very difficult to control the hypertension in the CKD with the 3 or 4 drugs. You need almost all the drugs to treat the hypertension in the CKD individuals. Usually necessary for an effective hypertension control in the CKD individuals. Choose additional antihypertensive agents based on the cardiovascular medication indications and comorbidities. Atherosclerotic risk and the special considerations. Assess the atherosclerotic risk. Consider the antiplatelet agents like your aspirin or the clopidogrel, unless there is an increased bleeding risk. Again, at a high level of the blood pressure, so don't use the aspirin or the clopidogrel, because the chances of hemorrhagic strokes are very common. Suppose the blood pressure is 200 by 140, so don't add aspirin. So this aspirin may cause hemorrhage in the presence of uncontrolled hypertension. So before to add the aspirin, so you have to see the blood pressure has to be reduced to at least to 150 or 140. Investigate the sleep apnea. As a potential cause of the resistant hypertension. So most of the CKD hypertension is the resistant hypertension. You know what you mean by the definition of the resistant hypertension. Okay. So you have to use at least 3 antihypertensive medications, the maximum dose, one being a diuretic. So in resistant hypertension, the common drug we use in a non-CKD population is the spironolactone. But here we can't use the spironolactone. This is the algorithm for the management of the hypertension in people with the CKD. The person has the CKD. Is the blood pressure consistently below the target? So the blood pressure target is less than 130/80. Yes, continue to monitor the blood pressure, manage the lifestyle risk factors. But most of the people, we don't reach the 130/80. So what? Start ACE inhibitors or ARB. Monitor the GFR and the potassium levels. Continue to monitor the blood pressure. Maybe consider the home monitoring. This is very, very important in CKD. Home monitoring of the blood pressure. A nocturnal blood pressure monitoring. Because the dipping and the non-dipping. Here, most of the CKD population are the non-dippers. Again, the non-dippers are at high risk of getting the vascular events. Manage the lifestyle factors. So mostly the cessation of the smoking, moderation of the alcohol, salt restriction, water restriction. So these are very, very important things to be seen. Is blood pressure continuously below the target? Still, most of the people know. Still, the blood pressure is 150/100, etc., etc. So what to do? Reinforce the medication. Reassurance, reinforcement, making more and more friendly with the patient. So whether the patient complaints is good or not. So most of the people, even though you prescribe 4 or the 5 antihypertensive medications, they may take only 1 or 2. So the compliance is very, very important. So check the drugs. So it's very, very important. Adherence. Increase the ACE inhibitor or ARB to the maximum recommended doses. Consider adding calcium channel blocker like your nifedipine or the cilindipine or the amlodipine. A diuretic, mostly the loop diuretic, your furosemide, maybe 80 milligrams, 120 milligrams, or 200 milligrams. Beta blocker, maybe a vasodilatory beta blocker, like your bisoprolol, maybe 10 milligrams, 20 milligrams, or lebuolol, 5 mg, 10 mg, etc. And then refer to a nephrologist, if the blood pressure is not consistently below the target with at least 3 antihypertensive medications. Yes. Is blood pressure constantly below? That is how we have to treat the hypertension in the CKD individuals. So use all the maximum doses like ACE, ARB, calcium channel blocker, beta blocker, even the alpha blocker, and central acting drug. These are the common drugs with the diuretics. High doses of the diuretics is the a good prescription to control the blood pressure and to reach your target of 130/80. Beta blockers, atenolol and the metoprolol aid the blood pressure control in the CKD, but they are not metabolically friendly beta blockers. See, the atenolol and the metoprolol, they cause hyperglycemia, they cause hyperuricemia, so they disturb the lipids, so etc. Okay, so contraindicated in asthma and the heart block because they are not cardio selective beta blockers, and atenolol is really renally clear. Calcium channel blockers suitable for angina. The elderly, so in elderly hypertension, isolated systolic hypertension, so obviously calcium channel blockers are very, very good on systolic hypertension. And to reduce the strokes in the elderly individuals, again the calcium channel blockers are the drugs of the choice. Mineralocorticoid receptor antagonists considered for the heart failure or the hypertension cautiously in the CKD individuals. So mineralocorticoid receptor antagonists, name 2 mineralocorticoid receptor antagonists. Spironolactone. What is the recent drug entered into the market? Starts with letter F. Finerenone. Okay, finerenone. Monitor, that is the steroid sparing mineralocorticoid receptor, available in the 2 strengths, 10 milligrams and the 20 milligrams. When the GFR is less than 30, use the 10 milligrams. When the GFR is between more than the 30, so you can go for the 20 milligrams. Finerenone. Kerendia is the brand name. It's a very good drug to use in the heart failure also. Heart failure and in the diabetic kidney disease. Clinical tips that temporarily discontinue the ACE inhibitors, ARBs, and the diuretics during the acute illness. ACE inhibitors and ARBs may cause reversible GFR reduction. Continue if less than 25% and stop if more than 25%. See the picture, diagrammatic picture. Nephron changes in the diabetes and after administration of an ACE inhibitor or angiotensin receptor blocker. See the first picture is the normal, the afferent arteriole and the efferent arteriole. See the afferent and the efferent arterioles, both are of equal caliber. That is a normal kidneys. See the diabetes. What happens? Afferent and the efferent. So the dilated afferent arteriole, whereas the constricted efferent arterioles. So that is the reason for your increased intraglomerular pressure. So that increased intraglomerular pressure will cause all of hangama in the kidneys, in the nephrons. So that is the most important in the picture, pathology picture. So what will happen when you use the ACE inhibitors or ARBs? Again, there will be the dilatation of your efferent arteriole by using the ACE and ARBs. So again become the normal. So this is a very important picture. It shows the constriction of the afferent arterioles. See in the second picture. See the second picture. Protein loss. See the marks inside. Dots. They are all the proteins. So in the diabetes, the proteinuria. So what happens when you use the ACE inhibitor or ARBs? The proteinuria has reduced to some extent. Okay, so that is the benefit of the ACE inhibitors or ARBs in a diabetic individual, because it dilates the efferent arteriole, it reduces the intraglomerular pressure, and it reduces the proteinuria. This is the current and the potential targets for the therapeutic interventions in the RAS cascade. See, you all know that here, this picture, angiotensinogen from the liver converted to the angiotensin 1 with the help of the renin coming from the kidneys. The angiotensin 1 will be converted to the angiotensin 2 with an ACE inhibitor, ACE enzyme. And the angiotensin 2 will act on the AT1 receptors and AT2 receptors and also acts on the aldosterone. So this is the very important. Yes. Okay. Now see here, angiotensinogen 1, you know angiotensinogen is the liver. So that will be converted to the angiotensin 1 with the help of the renin secreted from the kidneys. The angiotensin 1 will be released, converted to the angiotensin 2 with the help of the ACE, that is from the lungs. And angiotensin 2 will act on the AT1 and the AT2 receptors and also on the aldosterone. So the important thing here is angiotensin 2 will act mostly on the AT1 receptor. So the AT1 receptors, these will cause the inflammation, the proliferation, the fibrosis, and vasoconstriction. This is a potent vasoconstrictor, AT1. So not only that, see the aldosterone there. That aldosterone also will act in these things. So the aldosterone also will act on the inflammation, proliferation, fibrosis, and vasoconstriction. So you have the two drugs here. To block the angiotensin 2, here you are using the ARBs, which acts on the AT1 receptors. So to reduce the inflammation, proliferation, fibrosis, and vasoconstriction. And also you are using the aldosterone antagonists, like your spironolactone or now the finerenone. So they also will help you these things. So in that way, the development and the progression of the diabetic nephropathy can be controlled. Otherwise, so this is how this progression of the diabetic nephropathy occurs. So the first one is the angiotensin 1, not the 2 there. AT1 receptor. So that is a vasoconstrictor, cell growth, proliferation, CV hypertrophy, PA expression, aldosterone release, central sympathetic activation, sodium and water retention, and inhibits the renin release. So these are all the features of the AT1 receptor, and opposite will be the AT2 receptors. So this is the most important slide, shows you the measurement of the blood pressure is likely the clinical procedure of greatest importance that is performed in the slopiest manner. You got the point? So record the blood pressure in the slopiest manner, as slow as possible. Otherwise, you are missing the systolic blood pressure, you are missing the diastolic blood pressure. Accurate results of the systolic and the diastolic. So this is very important. Suppose if your value of the diastolic blood pressure is 200 by 140, you are using 3 or the 4 drugs. Suppose if your blood pressure is 140 by 80, your recording is 140 by 80, and you may use only single agent. So this is a very important. Measurement of the blood pressure is very, very important. So this is an impact of the sympathetic overdrive in the CKD. So what is the role of sympathetic overdrive? Okay. So increase the sympathetic overdrive in the young adult. The prevalence of the sympathetic overactivity in the newly diagnosed hypertensive patients in India to the tune of 62.42%. Okay. So 6 out of 10 newly diagnosed hypertensive patients in India have the sympathetic overactivity. Chronically raised sympathetic nerve activity is a powerful predictor of myocardial infarction. So in India, we are seeing a lot of the hypertensive population. Okay, almost I think 1/3 of India is having hypertension. So out of 140 crores, 1/3 means roughly 45 to 50 crores are having hypertension. So very high incidence of hypertension. All these people are mostly they have sympathetic overactivity. If left untreated, what will happen? Myocardial infarction. So while treating an young hypertensive in Indian perspective, so you need to understand a sympathetic overactivity and you need to start the drugs which reduces the sympathetic overactivity. More patients with CKD, they die of the cardiovascular complications than progress to the dialysis. So at the stage 3 and the 4, the die of the IHD or the myocardial infarction. So they may not land up with the stage 5 to need a dialysis. Over 80% of the CKD patients have hypertension, which is associated with the increased risk of the cardiovascular morbidity and the mortality. Not 80%, maybe 90 to 95%. Most of the CKD population will have hypertension. Very, very, very few people will have a normotensive CKD. Am I clear? So the hypertension in the CKD is very, very important to avoid the cardiovascular risk. Indeed, high sympathetic nerve activity is associated with the poor prognosis and increased cardiovascular morbidity and mortality, independent of its effects on the blood pressure. Mechanisms leading to chronic sympathetic excitation in CKD are complex, multifactorial, and to date not completely understood. Identification of the mechanisms and the signals leading to the sympathetic overactivity in CKD are crucial for the development of effective therapeutic targets to reduce the increased cardiovascular risk in this group. So this is the elevated sympathetic nerve activity independent of the blood pressure leads to. See the brain, that is the sympathetic nervous activity. That sympathetic nervous activity will act on the adipocytes, that is your fat cells, and also in the kidneys. So in the kidneys, because of the increased sympathetic nervous activity, more and more renin will be released. So you know what will happen to the renin. So your angiotensin 1, angiotensin, then 1 to the 2, and again it's the vasoconstrictor, it damages the vessels, and then there will be endothelial dysfunction, and finally myocardial infarction. In the same way, angiotensin 2 on the vessels and on the adrenals, there will be the aldosteronism and hypertension. So on one hand, they causes the hypertension, on the other hand, they cause the endothelial dysfunction. So exaggerated coronary vasoconstriction, arrhythmias, impaired renal function, glomerular podocyte injury. That podocyte is the most important one to cause the renal damage. So here the sympathetic nervous activity will kill the podocytes. Metabolic impairment, increased arterial stiffness, then their endothelial dysfunction because of the nitric oxide reduction and more vasoconstrictors. So all these lead to the increased risk of the CV events. So that is the value of the sympathetic nervous activity. Kidney as origin of the central sympathetic activity. See the kidney here. Yeah. See, increase renin release, RAS activation. So there is the increased sodium retention, and there will be the reduced renal blood flow will lead to the hypertension. Okay. So the afferent sympathetic activity in the heart, so the heart rate will be increased because of the sympathetic activity there, and there will be the increased contractility. So there will be hypertrophy because of the increased contractility, left ventricular hypertrophy, and there will be more and more oxygen is required, oxygen consumption, and there will be the arrhythmias. Okay. So what happens to the vessels? So there will be the vasoconstriction, and there will be the more and more insulin resistance and the hyperglycemia. So this is the activity of the sympathetic nervous activity. So the sympathetic nervous activity, they damage the kidneys, they damage the heart, and also the vessels. So this is the renin-angiotensin system, the renal afferents, nitric oxide pathway, and oxidative stress. So these are all related to your sympathetic nervous activity. So the more and more oxidative stress, less and less nitric oxide, that is a good vasodilator, and the renal afferents and the renin-angiotensin system. See, let us talk on the renin-angiotensin system. In addition to causing the direct peripheral vasoconstriction because of your AT1 receptors, they cause vasoconstriction. Angiotensin 2 also modulates the peripheral SNA by potentiating the norepinephrine release from the sympathetic nerve terminals. A chronic treatment with these drugs only reduces the, but does not normalizes it. See here, the same picture here. More than 50% of the deaths in the renal failure occur due to the myocardial infarction, stroke, heart failure, and sudden cardiac deaths. The latter accounting for 25% deaths in these patients alone. So that is the reason I am saying that most of the nephrology patients, they die in the hands of cardiologists. The CKD, even though the diagnosis of CKD, even though the CKD treatment is under the nephrologist for the last 3 years, 4 years, 10 years, 15 years, and finally the death certificate will be given by cardiologist. Because this CKD population, they get a lot of the myocardial infarctions, arrhythmias, accelerated hypertension, malignant hypertension, hypertensive urgency, hypertensive emergency, acute pulmonary edema, etc. So there is a growing evidence that sympathetic overactivity, a characteristic feature of the CKD, is one of the major mechanisms leading to higher CV risk in this patient population. Studies report the two major findings. So sympathetic nervous activity is augmented early in the CKD. Sympathetic nervous activity increases progressively with declining the renal function. So this is early in some cases, and after that, not only the early, progressively declining renal functions laterwards. So the most common detrimental sequence of elevated SNA is the hypertension, which is observed in 80% of the CKD population. So what can trigger the sympathetic overdrive? So the diabetes, the mental status, mental stress, obesity, smoking, hypertension. So these are the root causes for the death in the CKD population. So if the patient is a diabetic, treat aggressively the diabetes. You know how to treat the diabetes very aggressively with very, very less of the metformin, because the metformin less than the 30, you should stop it. Sulfonylureas, they cause more of the hypoglycemia. So if at all you want to use the sulfonylurea, glipizide is the good drug to be used here. Pioglitazone, so better to stop it because it causes the fluid overload and congestive heart failure. Alpha glucosidase inhibitors usually avoidable because they cause nausea, vomiting, abdominal cramps. Already that type of the symptoms are there in the CKD population. Gliptins, good drug in the CKD. Linagliptin, you can use it. And all other gliptins also you can use it with a reduced dosages according to your GFR. Whereas the linagliptin, you need not reduce the doses. And SGLT inhibitors, very, very good drugs in the CKD population in the initial days, like your dapagliflozin or the empagliflozin. And insulin is best from the day 1 to the last day in all the CKD population. But the only thing is, you have to see these people should not get into the hypoglycemia, because hypoglycemia is a very common side effect of the insulin therapy. So you should avoid the hypoglycemia in those population. So that is how you treat the diabetes in the CKD population. Mental stress is a very, very important, because of the decreased recognition, decreased concentration, more and more irritability, sleeplessness. So these are all the factors for your toxins, uremic toxins accumulating in the body. So the mental stress has to be reduced by some yoga, some meditation, or some music therapy, etc. Obesity is very important. So it increases the insulin resistance, endothelial dysfunction. So obviously it will lead to a lot of vascular events. Smoking in any form has to be reduced very effectively. Smoking cessation is a must in all the CKD population to avoid again a vascular ill health. Hypertension has to be treated with ACE or ERB, not both. You add calcium channel blocker, you add beta blocker, you add alpha blocker, you add central acting drug, you add loop diuretics. That's how we have to treat the hypertension very effectively in the CKD population. See, the best way of recording the blood pressure in a sloppiest manner. So characteristics of the high sympathetic overdrive in the youngsters: anxiety, panic, nervousness, insomnia, inability to relax, palpitations, breathlessness, higher resting heart rate, high BP, dyslipidemia. So we can say whether this fellow is having the higher sympathetic activity or not by seeing the heart rate. So when the heart rate is more than the 100, 110, 120, that shows more sympathetic overdrive. Okay. So in that way, you can identify these people in CKD individuals. The higher resting measurements of the sympathetic traffic are associated with a greater daytime blood pressure variability and a more marked nocturnal decline in the blood pressure in the normal subjects. These findings suggest that sympathetic neural mechanisms may contribute importantly to the regulation of the blood pressure over the 24-hour period. All type of the heart failures were more typical among the CKD subjects in comparison to those without the CKD. So congestive heart failure is commonly characterized by sustained RAS and SNS overactivation, promoting the higher sodium and water retention with increased vascular tone and structural cardiac, renal and vascular remodeling. So that is the reason I told you the 4 pillars in the management of the heart failure. What are they? ACE or ERB or ARNI, your valsartan and sacubitril combination. That is the one pillar that reduces your RAS activity. And the second pillar is beta blockers, vasodilatory beta blockers, like your carvedilol, metoprolol, or bisoprolol, nebulol. So they reduce the sympathetic nervous activity. And the third pillar is mineralocorticoid receptor antagonists. So they reduces your fluid and water retention. And the fourth pillar is SGLT2 inhibitor. So that's how we have to treat the heart failure. In the same thing here also. See the stress. Next one. The stress. So the stress will cause sympathetic nerve activity. So the obesity will have more and more leptin. So adiponectin is a protective. Adiponectin is at a lower level in a diabetes and obesity and other individuals. So whereas the leptin is an inflammatory cytokine. So that leptin will be increased in the obesity. They cause sympathetic nerve activity. So once the sympathetic nerve activity is there, so they act on the 4. One is the heart, then the peripheral artery, then the kidney, and the skeletal muscle. So the skeletal muscle, they cause insulin resistance, so more hyperglycemia. And the heart, peripheral artery, kidney, cardiac output will be increased, vasoconstriction, vascular resistance, sodium retention, renin-angiotensin system activity. So these all will lead to hypertension. See how beautiful they cause. So simple stress will increase the sympathetic nervous activity, and your sympathetic nervous activity, and if the patient is also happens to be obesity, so then will be augmented by your leptin levels, that inflammatory cytokines. So they different acts on the heart, your peripheral artery and the kidney to cause hypertension, and the skeletal muscle to cause insulin resistance. So hypertension is dangerous, insulin resistance is dangerous, all things because of the stress and sympathetic activity. See the cilindipine. So you have the calcium channel blockers, nifedipine, amlodipine, cilindipine. So cilindipine reduces the heart rate better when it is higher than the 35 beats per minute. So higher the heart rate, better is the reduction seen with the cilindipine. So that is the advantage with the cilindipine over the amlodipine as far as the heart rate reduction is concerned. Your amlodipine will cause reflux tachycardia. So amlodipine usage may cause headache, etc. The change of the glomerular dynamics, hemodynamics in patients with advanced chronic kidney disease after the cilindipine therapy. The systolic blood pressure reduction from 80% from the baseline. Glomerular capillary pressure on single nephron was reduced to 90%. In conclusion, finally, the cilindipine improves the what is ERPF? ERPF is effective renal plasma flow. So cilindipine improves effective renal plasma flow and glomerular hypertension without worsening the total renal function. So that is the benefit of cilindipine if you want to use it as a calcium channel blocker of choice in the CKD population. So newer CCBs like your cilindipine are designed to not only reduce the blood pressure but also have the beneficial sympatholytic action on the renal protection. So the key studies that establish the cilindipine and its sympatholytic actions. So there are the different journals. So they say that conclusions, American Heart Association, in patients with essential hypertension, cilindipine suppressed the cardiac sympathetic overactivity and amlodipine had a little suppressive effect. Cilindipine may provide a new strategy for the treatment of the cardiovascular diseases with sympathetic overactivity. Cilindipine significantly reduced the BP and the pulse rate in hypertensive patients at the clinic and at home, especially with higher BP and the pulse rate in the morning. So the L-type channels and the N-type channels, you have it. So whereas amlodipine, they have only the L-type of the channels. They are the renoprotective, cardioprotective, and neuroprotective because of these two channels. The CCP with the sympatholytic properties, a sympathetic overdrive is an individual contributing factor to the CKD and the CVD. Many youngsters, especially in India, present with a higher sympathetic nerve activity. N-type calcium channels is also the sympathetic nerve activity. Newer CCBs like cilindipine have suppressive effects on the N-type. This effect may improve the glomerular hemodynamics. Cilindipine has increasingly shown to have promising evidence in the morning hypertension, nocturnal hypertension. So these are very, very important to reduce the overall sympathetic activity. Now move on to the CKD and diabetes. So we discussed about the CKD and hypertension. So a lot of the drugs we discussed, and we also discussed the role of the sympathetic activity, overactivity. Now the CKD and the diabetes, in type 2 diabetes, 1 in every 2 individuals visiting the primary care will have a CKD. So very common. As I told you, the incidence wise, 50% of the ESRDs are hypertension or diabetes. Diabetes has a key risk factor. Diabetes significantly increases the risk of CKD. 40% of the CKD cases are attributed to the diabetes. Kidney disease is a pivotal indicator of cardiovascular disease in the risk in the diabetes. Diabetes exacerbates outcomes at all stages of the CKD. So early detection and proper treatment measures can slow or halt the progression of CKD in individuals with the diabetes. So that is the reason in all the diabetic individuals, you have to see the renal function. So how is the urea and creatinine electrolytes in a type 2 diabetic individuals, even on the day of the diagnosis of your type 2 diabetes. It is a silent killer. Okay. See, the no signs or symptoms until more than 70% of the kidney function lost. It's an asymptomatic disease like your diabetes. So that is the reason type 2 diabetes is there in an individual which is an asymptomatic. In the same way, CKD also will be there in the patient which is asymptomatic. That is the reason sometimes the type 2 diabetes will be diagnosed by the nephrologist. So by the time their creatinine level is 3 or 4, when they approach to a nephrologist, then if you see the HbA1c or the blood sugars, they also at a higher level. So that means that this fellow has been living without knowing that he is living with both diabetes as well as the CKD because of the asymptomatic nature. See, from the time of the diagnosis of the type 2 diabetes, annual rate of progression of the microalbuminuria is 2%. Annual rate of progression of the macroalbuminuria is 3%. And annual rate of the progression to the severely reduced renal failure is about 2.5%. See, the renal disease associated with the increased all-cause mortality. See, if you see this slide, the first one is the previous myocardial infarction. And the third one is the CKD. And the fourth one is the diabetes. And the last one is the no diabetes or the CKD. And the second one is a diabetes and CKD. See the all-cause mortality. Okay, so diabetes and CKD is at a higher mortality rate when compared to the previous MI or CKD alone or a diabetes alone. So that shows that diabetes and CKD is a very, very, very high mortality disease. Here again, mortality is more frequent type 2 diabetes with kidney diseases than in those without the diabetes. See in the first one, no kidney disease. Second one, there is albuminuria. In the third one, there is impaired GFR. And the fourth one, albuminuria and impaired GFR. And the last one, no diabetes or no kidney disease. So the fourth one is more mortality, excess mortality is because of both albuminuria as well as impaired GFR. So in all the diabetic individuals, so you have to respect the albumin levels and also the creatinine levels to know the GFR and treat accordingly. Otherwise, will lead to lot of morbidity and the mortality. So you can't cure it. So you have to endure it. Endure it means you have to progress it. You have to follow it. Even though we have a lot of the obstacles or mishappenings. So that is the enduring. So when you can't cure the diabetic renal disease, so you have to endure it. So this is the diabetes diagnosis. Then you will have the hyperfiltration. Then you have the clinical latency, micro, macro, and renal failure. So earlier, microalbuminuria, now the new terminology is high albuminuria. Earlier, macroalbuminuria, now the new terminology is very high albuminuria. Only we call it only albuminuria, whether the micro or macro. Okay. See the natural history. So there are the functional changes, then the structural changes. So functional changes, increase in the GFR, reversible albuminuria, increase in the kidney changes. Structural changes, glomerular basement membrane thickness, mesangial expression. And then the early nephropathy, you will have the microalbuminuria and rising blood pressure, and onset of the proteinuria, rising serum creatinine, etc. So in all the diabetic individuals, if the patient is also having the hypertension, that means already there is some element of the kidney involvement in those individuals. So what will happen? That is the type 1 diabetes. In the type 2 diabetes, diagnosis, even at the microalbuminuria, straight away. Okay. Sometimes no, even at the macroalbuminuria, even at the time of the diagnosis, sometimes even they diagnose as the renal failure. But unfortunately, we are having more and more type 2 diabetes in India. So that one is the type 1 diabetes. So in India, some people they present with microalbuminuria. We are happy if you diagnose the microalbuminuria, start ACE inhibitors or ARBs. Some people they present as macroalbuminuria. Okay, when the protein is more than the 500 milligrams. So again, we can use the ACE inhibitors or ARBs if the patient happens to be hypertensive, control hypertension very effectively. If the person is a smoker, advise not to smoke. If they are obese, so advise to weight loss, etc. So all these things we do it. Sometimes no, the people they along with the diabetes at the time of the diabetes diagnosis, already creatinine is 2 or 2.5. So this is the very, very important. So that is the reason identification of the diabetes before the complication is much more important to have a good quality of the life. So the glycemic control for the CKD progression, the crucial for delaying the CKD progression. Most guidelines recommend a target hemoglobin A1C of around 7%. So it depends on the individual. Suppose if the person is elderly with a lot of the comorbidities, even you can keep the A1C at 7.5 or the 8%. Drug clearance considerations, avoid kidney related drugs, clear drugs like lebeneclamide, very long standing agent, sulfonylurea. If they cause hypoglycemia, they will last for about 2 to 3 days. So better to avoid a long standing sulfonylureas in the renal failure population. If you want to use the sulfonylurea, what is the best sulfonylurea to use in the CKD? Shortest acting sulfonylurea. That is good. What is that? Glipizide. Liver and metabolism excreted drugs like metformin, BP4, SGLT inhibitor may need the dose adjustments, especially with the GFR less than the 30. Suppose metformin, we stop using less than 30. We can use more than the 60, you can use the usual dosages. When the GFR is between 30 and the 60, you have to reduce the dose of the metformin. DP4 inhibitors, already told you, linagliptin and other gliptins. SGLT inhibitors, already I told you. You can use the dapagliflozin till the GFR is 30. Consider the SGLT inhibitors for those with a severe albuminuria. See, these are all things already I told you. Metformin, SGLT inhibitors, DP4 inhibitors, sulfurias. Insulin is the good drug. See the diabetes and more mortality. See SGLT inhibitors. See here, SGLT inhibitors. So earlier, if you use the sodium and the glucose reabsorption, amplification, and finally the mortality. So use the SGLT inhibitors to reduce the sodium reabsorption, to reduce the cardiac preload and the afterload, to reduce the cardiac expenditure, energy expenditure, to avoid the diastolic dysfunction, and then to avoid the systolic functions, etc. So the Lina is a good drug. So it effectively in patients with the different stages of the renal impairment. Albuminuria lowering by the linagliptin is independent of the improvement in the glucose and the blood pressure control, because inhibition of the podocyte, inhibition of the podocyte damage, inhibition of the myofibroblast transformation, increase the GLP-1 receptor expression in the kidney. See, this is how the renoprotective effects of the linagliptin may be due to inhibition of the podocyte damage. The podocyte is very important to cause the nephropathy. So here, this linagliptin will inhibit the podocyte damage so that there is a renal friendly gliptin. So reduce the sodium in the diet, that's a DASH diet. Reduce the carbs and the fats, saturated fats and trans fats has to be reduced. Reduce the weight if they are overweight. Reduce the BP if they are hypertensive. Reduce the lipids if they are dyslipidemic. Stop smoking if they are smokers. Use RAS inhibitors in all the individuals, and use SGLT inhibitors like DAPA in all the individuals, and also GLP-1 receptor agonists, either parenteral or the oral. Pregnancy and the diabetes, hyperfiltration states. Both are hyperfiltration states. Increase in the GFR by 40%. No progression to the CKD in pregnancy and no proteinuria. Whereas progress to overt nephropathy with renal impairment ESRT. Why? See, in both the pregnancy and diabetes, there will be hyperfiltration. In both, they increase the GFR by 40%. But in pregnancy, no progression to the CKD, whereas the diabetes progress to the CKD and ESRD. And 50% of the people will have no ESRD. Why? Because efferent arterial hyalinosis and increase in the intraglomerular hypertension does not occur in pregnancy. So these two will occur in the diabetes, leading to the CKD and ESRD because of the intraglomerular hypertension and efferent arterial hyalinosis. So these are all ARF in the diabetics. UTI, you can answer it. Compared to the non-diabetics, diabetics are at increased risk of UTI. Yes. Compared to the non-diabetics, diabetics are at increased risk of the UTI. Yes or no? Compared to the non-diabetics, diabetics are at increased risk of complicated UTI. First one is no, second one is yes. So this is the CKD risk factor management. Hyperglycemia, I told you. Hypertension, I told you. Proteinuria, I told you. Dyslipidemia, you have to use the statins. But better not to combine the statins and the fibrates in the CKD population. Because if you combine the statin and the fibrate, the chances of elevation of your creatinine levels are higher. Smoking cessation, diet I told you, weight I told you, exercise is good, BP goals are good, LDL-C cholesterol goals good with your statins, maybe 10 mg, 20 mg, 40 mg. And glucose with insulin or with the gliptins or SGLT inhibitors, you can control it. Management of ESRD. Less than 2% of the patients of diabetic renal disease require RRT, that is renal replacement therapy, because others often die of CVD before reaching the ESRD. Most of the people, they die prematurely because of the atherosclerotic cardiac disease. Dialysis. Get an early vascular access for the hemodialysis, your AV fistulas. Offer PD, your peritoneal dialysis, to patients with adequate manual dexterity. Transplantation, renal and renal pancreas transplantation if the patient is supposed to be the type 1 diabetes. Preemptive transplantation, evaluation for the CAD. So before the transplantation, all the people will be subjected for the coronary angiogram to rule out the asymptomatic or undiagnosed coronary artery disease. So these are all the lifestyle changes, your healthy diet, your physical activity, your smoking cessation, and your weight management. First line drugs. So these are the first line drugs. Role of mineralocorticoid, I already told you. See the spironolactone, eplerenone. Now the third drug is the finerenone. So that is a novel non-steroidal mineralocorticoid receptor antagonist. It represents a new class of MRAs, shows the efficacy in the CKD patients with type 2 diabetes, a potential impact on the cardiovascular outcomes, and monitoring the renal function during the treatment. Again, potassium levels you have to think of. So when there is an hyperkalemia, so better not to use the finerenone. See the relationship of the cardiovascular disease and the CKD. So we discussed about the hypertension and CKD. We discussed the diabetes and CKD. Now the cardiovascular disease and the CKD. What are the traditional risk factors? You know them to have the so yes, obesity, males are more prone, tobacco, a family history, hypertension, diabetes, uricemia, dyslipidemia, etc. What are the specific risk factors? They are the toxic metabolites because of the CKD, uremia, albuminuria, vascular inflammation, oxidative stress, your sympathetic activity, endothelial dysfunction, anemia, and malnutrition. So they cause myocardium and the blood vessel remodeling. So leads to atherosclerosis, arterial stiffness, cardiomyopathy, and calcification. So finally, either ischemic heart disease or heart failure, CVA, CV deaths, or renal progression. See how beautiful it is. So when you're treating a CKD individuals to avoid the cardiovascular diseases, so these are all you have to address. Both the traditional risk factors as well as the specific risk factors. So anemia has to be corrected, malnutrition has to be corrected, okay, and then oxidative stress has to be corrected by control of your diabetes, hypertension, etc. So finally, they lead to the artery calcification, arterial stiffness, atherosclerosis, and cardiomyopathy. So leads to either ischemic heart disease or heart failure or CVA or sudden cardiac death or any progression of your CKD much further going for the ESRT. See, I told you hypoglycemia is a very, very dangerous for the heart. Causes arrhythmia. See here, hypoglycemia, sympathoadrenal activation will lead to both the hemodynamic effects as well as the electrophysiological effects. Hemodynamic effects, it causes the ischemia and infarction, and electrophysiological effects, they cause arrhythmias and the ectopics. So EP study, electrophysiological study. So that will pick up your arrhythmias and the ectopics. Your coronary angiograms, etc., they pick up the myocardial ischemia and infarctions. So these both will be seen in the presence of the hypoglycemia. So hypoglycemia has to be corrected very effectively, not to have the hypoglycemia in all the people because of to avoid the deleterious effects on the heart, both the hemodynamic effects as well as the electrophysiological effects, so that you can avoid the ischemia, infarction, arrhythmias, and ectopics. See, reducing the risk of the cardiovascular disease in the CKD population. Prothrombotic state. So interventions, aspirin therapy. Dysregulation of the lipid metabolism. Use the statins. Increased oxidative stress. Antioxidant therapy. Hyperphosphatemia. So use the bone mineral management like non-calcium based binders compared to the calcium based binders. Hyperphosphatemia, okay, and hyperhomocystinemia, your folic acid, homocysteine lowering therapy like with the folic acids, and anemia from the platelet dysfunction. So normalizing the hemoglobin with your iron or the folic acid or and also erythropoietin levels. Okay. Now the cardiorenal syndrome in the diabetes. What you mean by the CRS? Cardiorenal syndrome. It's a condition characterized by the initiation and progression of the renal insufficiency secondary to the heart failure. Secondary to the heart failure, there will be the renal insufficiency. And also use the negative effects of the reduced renal function on the heart and the circulation. So vice versa. So cardiac insufficiency will lead to the renal insufficiency, and renal insufficiency will lead to the cardiac insufficiency. That is the cardiorenal syndrome. What are the mechanisms involved here? The RAS activity, sympathetic nervous activity, reduced oxygen, reactive oxygen species, that is more oxidative stress, vascular inflammation, endothelial dysfunction. So these are all the effects which cause the different mechanisms in your CRS. So this is the different classifications. Class 1, 2, type 2, 1, 2, 3, 4, 5. Acute CRS, a chronic CRS, or acute RCS, or chronic RCS reversible, or secondary to the cardiorenal syndromes. Effect of the CV death increases as the kidney function declines. So the low GFR and high urinary albumin creatinine ratio are independent predictors of the renal events in the type 2 diabetes. C. Blockade of the sodium hydrogen exchange by the SGLT inhibitors. So they decreases the cardiac injury, increases the sodium excretion, decreases the body weight, decreases the blood pressure, hemo concentration. So these are all the benefits of your SGLT inhibitors. It helps both the renal as well as the heart. So the drug of choice in cardiorenal syndromes. So now the diabetes, hypertension, heart and kidney. That is a deadly quartet. So the deadly quartet is heart, kidney, diabetes, hypertension. Very, very common in our areas. Okay. So the glycemic control, blood pressure control, vascular control, lipid control, and lifestyle measures. These are very, very important. Monitoring of the established CKD and the treatment complications. How you monitor? So they recommend the annual monitoring of the GFR and albuminuria. High risk patients, semi-annual monitoring, maybe once in 6 months or once in 3 months. Anemia and the role of erythropoietin. See, the initial anemia of the CKD is related to reduced erythropoietin production by the kidney, resistance to the action of the ESA, reduced absorption of the iron, usually starts to develop when the GFR is less than 60 ml. What is your target hemoglobin here? 10 to 11.5, 10 grams to 11.5 grams. Initiation phase, you commence the treatment aiming for the target hemoglobin. Your target hemoglobin is minimum 10 grams. Monitor the hemoglobin every 2 to 4 weeks. Iron stores monthly. Gradual rise of 10 grams per month. Rapid correction, 1 gram per month. 10 grams per liter here. Rapid correction linked to the hypertension and seizures. So these are all the electrolyte, minerals and the bone abnormalities in the CKD. Diet in CKD, choose and prepare the foods with less salt and sodium. Right types of the protein is very important. Healthy for your heart. So limit the protein, people with the kidney disease. Increase the protein, people with the kidney disease, stage 5. So when the fellow are on dialysis or for the renal transplantation, no limit in protein intake, maybe increase in the protein. In fact, no limit in the protein intake for our Indians because our diets are very, very poor with protein content. So you can use the usual protein content in all the CKD population in India. Then choose foods and drinks with less phosphorus. Choose foods with right amount of the potassium. So this is very important. Modify your diet to restrict the potassium and phosphorus intake for the kidney protection. Exercise, staying fit with the kidney disease, staying fit with the benefits of exercise, improves the physical functioning, better blood pressure control, improve the muscle strength, lower level of the blood fats, better sleep, better control of the body weight. So these are all very important. So decrease the fluid intake to 1 liter per day, and you have to respect the urine output in CKD. Decrease the protein by 0.5 to 1 gram per kg body weight. Decrease the sodium, very, very less sodium. Decrease the potassium. Decrease the phosphorus. Your dialysis is of choice, either peritoneal or hemodialysis. And RBC protect the, maintain the normal RBC, so that anemia, etc. correction. And vitamin D, at least 60,000 once in a month. So hemodialysis versus the peritoneal dialysis. Here osmosis, diffusion, ultrafiltration. This is how the peritoneal dialysis is being performed here. Hemodialysis, your SS, your AV fistulas. So this is the machinery, circuit, hemodialysis circuit. So PD advantages. So no need of hospitalization, can get it at the house. Less complicated, the portable, shorter training time, less cardio stress, choice for the diabetics. Disadvantages, peritonitis. So subacute bacterial peritonitis or the chemical peritonitis is a very common in peritoneal dialysis. Protein loss is more. Hemodialysis advantages, rapid fluid removal, rapid removal of the urea and creatinine, effective potassium removal. So these are the advantages. And disadvantages, hypotension, extensive equipment, heparinization, and vascular SS problems. So disequilibrium syndrome will be there. Renal transplant, you will have the living and the cadaveric donors. So immunological compatibility is very important. Your human leukocyte antigen HLA, this gives you your genetic identity. So white cell cross match, a positive cross match, mixed lymphocyte cultures, ABO blood grouping. So the complications, the resection is a major problem. So you have a hyperacute resection. That means within the minutes, 2 hours after the transplantation. Because of the renal vessel thrombosis, no treatment, and the transplanted kidney is removed. Very, very, very unlucky population. Hyperacute resection. Then the acute resection. It occurs 4 days to the 4 months after the transplantation. It is not uncommon to have at least one resection episode. Episodes are usually reversible with the additional immunosuppressive drugs like your corticosteroids, etc. The signs of you note that acute resection, there will be increase in the serum creatinine level, elevated BUN, presence of the fever, more weight gain, decreased urine output, increase the blood pressure, and tenderness over the transplanted kidneys. That's how you define, you recognize acute resection. So treat them with good amounts of the corticosteroids and other immunosuppressive drugs. Then the chronic resection occurs over the months or the years and is irreversible. So the kidney is infiltrated with a large number of the T and B cells, characteristic of an ongoing low-grade immunological mediated injury. Gradual occlusion of the renal blood vessels. Here the signs are the proteinuria, hypertension, increase in the serum creatinine levels. Your supportive treatment, very difficult to manage, replace on the transplant list. Other complications, infections are very common in this population. So both the bacterial and viral and fungal, all infections are very common in post-transplant people because they are on high amounts of the steroids and immunosuppressive drugs. Hypertension is common. Malignancies are common, especially the lip and the skin, lymphomas, cervical. Recurrence of the renal disease, retroperitoneal bleed, arterial stenosis, and urine leakage. So in conclusion, a comprehensive well-being, lifestyle and nutrition, emotional health, symptom management, quality of the life, personalized care, foster long-term resilience with a holistic mindset, And beyond the medical, embrace a holistic mindset, going beyond the medical interventions for the sustained well-being. So thank you very much for your patience here.